says that there are lots of inborn metabolic errors in Nepal, metabolic disorders in Nepal, and of course the hemoglobinopathies. There are lots of cases of hemoglobinopathies in the newborns, and there are lots of pilot studies also. And one pilot studies from the newborn is newborn screening for selected disorders in Nepal, which was carried out in around 5. These are the studies regarding the feasibility to conduct the newborn screening in Nepal. So feasibility studies has also been done. So lots of works has been done in studies in part of studies. So another evidence, as I talk, is before is the mortality. So as you can see, the neonatal mortality rate now in Nepal is 16.6, and then the infant mortality rate is 23 deaths per 1,000 live birth. And as per the UN Sustainable Development Goals, the target of Nepal is to decrease the death to 13, the neonatal mortality rate to 13 per 1,000 lives. And the government is challenging in this, so they are not able to decrease the mortality rate as per the goal. And there's something like newborn conditions might be the reason or link with this, these conditions might be responsible for not decreasing the mortality in the newborns. And from yesterday's panel discussions, there was some presentation, there was some findings that congenital defects are also involved in, is responsible for the mortality rate in countries. So this is also the evidence, and besides this, there are also the disability studies where lots of children in Nepal has disabled. So there is a high disability rate also. So that might be also the result of the congenital conditions due to the lack of newborn screening. And another is the physician's experience, as I explained before, I talked before. So that physician's experience has been published as a case reports, so that these are also the evidences, and some has been not published, but in the line of publication. So these all shows the evidences of newborn condition, like problem, public health problem in the Nepal. So then if there is issues, there are the issues regarding the newborn screening, newborn health, then who are the responsible stakeholders to take care of this? So I've listed some, so like Ministry of Health and Population, they might be the first one to take care regarding these situations, and then public health professionals, hospitals, private and government hospitals, clinicians, mostly neonatologists and pediatricians, and then national societies, different national societies, WHO, UNICEF, who are working in the child and maternal health, and INGOs. So what these stakeholders are doing, are there any activities and actions regarding to address the newborn screening in Nepal? So let's see. So Ministry of Health and Population have one division, that's the Family Welfare Division, that are looking for the maternal and the child health. So they have just published, they also shared us some documents yesterday. So they have published one document, a policy document, that's the 5 years plan. So that includes the statement regarding the screening for the birth dates, and I think there is one clause where they have also mentioned the congenital hypothyroidism to be started in Nepal. So that's the good steps or initiations from the government side. And besides the laboratory tests like dry blood screening, they have also started the newborn hearing screening and ophthalmological screening, and screening for the neonatal jaundice, and that in the collaboration with the WHO. And the Fotoghar Maternity and Women Hospital, which is the government-based hospital, has already started screening the newborn at their center. They have started on October 2024. And at Very Hospital, under the initiation of Dr. Rajan, they have started screening for the hemoglobinopathies in the newborn, and that only in the dry blood sample. So besides the government, there are some health institutes which are working on the newborn screening. So Tribhuvan University Teaching Hospital Institute of Medicine, they are also working to establish the newborn screening in their center. And Dhulkhela Hospital, they have started to test the TSS for the congenital hypothyroidism. And I think they are taking the venous blood to assess the hypothyroidism there. And Kathmandu Institute of Child Health, I think lots of pediatrician today is from this institute. They're also working on to establish the newborn screening at their center. And Patan Hospital, lots of research is going on, and they're also working on to establish the newborn screening in Nepal. So Health Institute are also currently active in establishing the newborn screening. So if you look at the WHO and UNICEF activities, so the WHO, as I said before, has one guidelines that deal with screening of hearing defect and eye defects, and then the neonatal jaundice. So they are collaborating with our government regarding this, and UNICEF, they have a good program of this early identification and early interventions which are looking after the neonatal and maternal health. So there are some societies which are advocating for the newborn screening. So we have NEPAS, that's the Nepal Pediatric Society, which are advocating for the establishment of newborn screening. So they are collaborating with the governments since 10-15 years that we should start the newborn screening in Nepal. And recently we have a newborn committee in Nepalese Association for Clinical Chemistry, and it's also working by collaborating with the international societies to get to establish the guidelines for the newborn screening. So there are lots of activities going on, and there is lots of individuals who are working on the newborn screening, and so all of them are working individually. So they are separately working to establish the newborn screening in Nepal. So the energy is diverging. So when I come to contact with the IFCC representatives, then what they first suggest is there are lots of people working on the newborn screening, and so your energies are diverging. So why not you converge the energy and work together to establish the newborn screening in Nepal? So that hit our mind, and then BTC start working on this. So there are lots of stakeholders who are working, their energy are diverging. And then IFCC and ISNS acts as a magnifying glass for us. So it starts to work and guide to conserve the energy and to converge the energy. So now we are in the path of converging our energy to ignite the newborn screening. So this gave us the fuel. So this is the initiation that we are starting the newborn screening in Nepal. So after this, the third essential for the newborn screening is the platform. So if there is the issues, and there are lots of organizations which are working on these issues, then do we have the platform to diagnose it here in Nepal? So I would like to share one project we did in SOMEC Diagnostic back in 2016. So back then there was no available systems to test to diagnose the newborn screening. So what we did that time was we manually extract the samples from the dry blood sample. We punch the dry blood sample paper, and then we put it in like the chemical like phosphate buffer solution with twin, 0.05% twin and 0.08% sodium azide, and we keep that overnight, and the elute we centrifuged and try to analyze the supernatant with the CLIA system. But unfortunately we could not verify that, and there is some issues with the reagent supply also, so we could not continue that project or that system in Nepal. But now I think there are lots of good systems available in Nepal, including Revity lab systems and the Fengua. And some of these has already been installed in Nepal. So the maternity and Fotoghar Maternity and Women Hospital, which is the pioneer to establish the newborn screening in Nepal, so in the government field, from the government side. So they have already started this, and there is a RBT system in National Path Lab. They are the reference lab, so they have started this screening there. And the Fengua system has been installed in the Seti Provincial Hospital for this diagnosis. So these are all, I think, immunofluorescent assays. But we have the other systems like the mass spectrometry, and as these are a bit expensive, and the test also going to be expensive, costly for the newborn screening. So we might have to think about which system is good for Nepal. Then comes the trained manpower. So do we have the skilled manpower, or the government has trained the skilled manpower for the newborn screening? So there is one project, like there is one system to train the nurses. So for the midwife nurses, our government has started the curriculum, which includes the newborn blood sampling in the dry blood sample techniques. So they have been trained for that. So currently we have some manpowers to collect the dry blood samples. And then comes the laboratory technicians. So are there the well-trained laboratory technicians to operate these systems as I described before? I think we have two scientists from Nepal who traveled to abroad from the IFCC PEP program to train in the mass spectrometry. So beside that, also we have, I think, some of the technicians who are trained in the MS also. And for the above already mentioned techniques like TR-IFA, I think it doesn't need any trained manpower. So we have to discuss which kind of platform will be feasible for us and appropriate for us. So lastly, the awareness. Are the public aware about the newborn conditions and the public health conditions, the seriousness of the condition that can be to their children, to the newborn childs? But unfortunately, from the government side and the public side also, there are no such awareness program till now to the public that there is issues and there is problem regarding the newborn child in Nepal. And regarding the awareness in the health professionals itself, there are very few programs conducted regarding the awareness of this newborn screening and the conditions that should be screened in Nepal. So I think today's and yesterday's program is the one of the first in one of program in this newborn screening sector, which has advocated and tried to share the awareness regarding the newborn screening in Nepal. So there are lots of activities going on in Nepal, so lots of stakeholders are working on the Nepal. We have the evidences, we have the technologies like platforms, diagnostic platforms here. We have the trained manpower also. Only thing is, we are not coming together to work to establish the newborn screening. Now, this is the right time that we all come together, and I know you all are have something in mind that this is the time to start the newborn screening in Nepal. So, if we look at the history in the world and other countries, the newborn screening has established only by working together, like different stakeholders, including endocrinologists, pediatricians, and then lab professionals, public health professionals, government. So this is a teamwork. So if you work together, then the carving of this newborn screening sculpture in Nepal is not too far. So let's work together and work for the newborns and work together to save the lives of the newborn. Thank you.
Thank you. Thank you, Dr. Santos, for this wonderful presentation. I think you have perfectly laid the foundation for today's discussion. You have shown us the powerful map, the territories that we have covered, and still the areas you have shown, we still need to navigate. So the floor is open for question. If you'd like to ask any question, please feel free to raise your hand, and Dr. Santos will be happy to answer. So let's not just be attendees, let's be architect. Thank you, otherwise we can move to next session. Thank you.
Thank you so much, Dr. Santos, for highlighting the efforts and evidence-based approach for the newborn screening program to be conducted in Nepal. He have highlighted many current scenarios, including global as well as Nepalese scenarios. So I think that will be a perfect starting for our seminar. So a joint task force of International Federation of Clinical Chemistry, IFCC, and International Society of Newborn Screening, ISNS, is dedicated in advancing newborn screening initiatives in low and middle income countries by promoting innovative and sustainable approaches as these countries continue to experience challenges including limited health facilities, limited health capacity, financial limitations, and training barriers. So this initiative seeks to identify and evaluate and promote the context-appropriate solutions, integrating both conventional and emerging approaches to address newborn screening for resource-constrained settings, such as Nepal, we can say that. So to highlight the contribution of IFCC, ISNS in the global newborns scenario, I'd like to welcome Dr. Aisha Habib Khan. So let's put our hands together for Dr. Aisha Habib Khan.
Thank you, Santosh and team for inviting me, and a very good morning and namaste to everyone. I will talk about, it's a privilege to be here in Nepal, and it's a great pleasure to see that how you people are doing great to bring newborn screening from intent to impact. And we at IFCC and ISNS have seen that how networking and mentorship can create, changes and bring dreams to vision. So with this, I have nothing to disclose, and here is an outline of my today's talk. And I will update you about the global status of newborn screening, and this has been extensively covered by Santosh already. So I'll just sensitize, and then I'll talk about how the IFCC, ISNS task force came into being, and then its purpose, the working, and the progress that it has made. And then I will also cover some barriers and challenges in implementing newborn screening program that has been reported from the literature. And I will talk about the new developments and way forward and how we can keep expanding newborn screening around the world. And this is an expect for experts from this paper, that it is the responsibility of experts and companies experienced in current NVS application, who are usually from high-income countries, to assist developing programs in LMIC's setting as they attempt to implement newborn screening programs. So with this, there's beyond this spot and in line with WHA, World Health Assembly 77 agenda, universal newborn screening can help improve outcomes that we all know by now, that by early management of treatable childhood non-communicable diseases. And while these programs are very well established in many high-income countries, but many low middle-income and upper middle-income countries, they continue to struggle to have universal newborn screening for common childhood NCDs. And therefore, there are unacceptable outcomes. So there's a considerable interest in scaling newborn screening activities to achieve the United Nations SDGs goal by 2030. And provided this newborn screening can be conducted ethically, safely, and cost-effectively in low-resource settings where access to management may be limited. So with this, it has been clearly shown that newborn screening is one of the most transformative public health initiative of our time. And from its humble beginning in the United States, in 3 states in 1963, it has grown into a global movement and now reaching 40 million babies who are tested each year. So what it started as a single test for one condition has evolved into a comprehensive program which now is screened for 61 conditions in the recommended universal screening panel. And most developed countries are routinely screening for 30 different conditions. So it is estimated that about 750 million babies have been screened so far, and more than 500,000 children have received early treatment as a result of it. So think of it for a while that, these babies were given a chance to lead a healthy life because their condition was caught, symptoms appeared. So wherever this newborn screening is in place, it is welcomed by parents, by clinicians, and health policy makers. Developed countries, I think Santosh also showed that it's typically more than 99% coverage. And because of this, it has been described as one of the major public health advances of the 20th century. And the diagram, the figure that here you see is of one of biotinidase deficiency. And you can see the difference that simple treating with biotin, which is a vitamin, can make so much difference in the presentation from a disease to a perfect. This audience is how there's a wide variation across countries, and because this is because of the government priorities, different variations in the conditions, variations in the prevalence, and most importantly, the priorities and also the facilities, the resource capacity building. And according to a United Nations estimates, approximately 40 million babies per annum are screened, which is around 32% of an estimated 140 million births each year. So there's a lot that we need to do and much to achieve. And this is the status of newborn screening programs in the Asia-Pacific countries. And as you can see, that within the Asia-Pacific region, there are countries who have very good coverage. And like Singapore, like Malaysia, and then Thailand, Vietnam are also doing very promising progress. Philippines is one such example. And Indonesia, earlier this was very low, but over the last 2 years, they are able to cover for 46%. But countries like India, Bangladesh, Pakistan, and Nepal, they continue to have very low coverage and low progress in the region. So, and just to tell you this example of sickle cell disease and congenital hypothyroidism, sickle cell disease is highly prevalent in sub-Saharan Africa, and the less than 5-year mortality of children is 36.4%, where excess mortality is 29.6%. So if you assume that 300,000 babies are born with sickle cell disease, almost 90,000 babies die each year. And for congenital hypothyroidism, which has a global incidence of 1 in 3,000, and if we assume that 140 million babies are born each year, 95 million are in unscreened areas, and more than 30,000 children per year are declined early and effective treatment for congenital hypothyroidism with lifelong consequences, with morbidity, so much morbidity, and thyroxine, which is the treatment, is so simple to give, and it's very cheap treatment. So, these figures, these numbers, they are just not just number and stats. They represent families, their futures, and their fundamental rights to health. And because of this, data compels us to believe that newborn screening for sickle cell disease and congenital hypothyroidism is not optional, it is a practical imperative. And when we look at this data and we look at the progress, we see that little has advanced in terms of the proportion of babies screened for congenital hypothyroidism in the last 10 years. And so if you look at the literature, there is an increase from 29.3% in 2014 to 29.6% till December 2024. So the proportion of babies screened is not increasing around the world. And what happens that external funding, people rely on external funding, but external funding is very challenging and may not result in sustainable program development. Programs funded in this manner can cease when external funding is no longer available. And treatment, again, treatment is very important because that loop has to be closed. And treatment can be difficult to organize and deliver in countries without an accessible national health systems. So and because of all of this, a joint task force was envisaged in 2020, and where ISNS and IFCC come together to help develop appropriate screening programs worldwide. And this is through support networking, like this session today, and information exchange activities, because mentoring helps a lot in creating what Santosh very beautifully showed, concerted efforts. So the main scope and the mandate of the task force is to engage and raise awareness, then identify countries, candidate regions and candidate countries, and then engage their local advocates and key national health policy makers to plan and conduct pilot activities, and thereby facilitating sustainable nationally funded programs through local commitments. And local commitments is the most important aspect, because experts, global experts will come and go, but ultimately it's the local experts who will be doing all the work. So what we did was initially that we set the stage by creating awareness and education across countries using IFCC and ISNS network. CME webinars were conducted, and then a need assessment survey on newborn screening was conducted in 2021. And we received 425 responses from 84 countries across IFCC and ISNS network. And most countries who were screening, who had already available screening programs, the top 4 disorders screened included congenital hypothyroidism, PKU, phenyl ketonuria, CAH, and cystic fibrosis. And 92% of these countries were using capillary heel stick. Then the most respondents in the survey supported a partnership with IFCC, ISNS regarding education, materials, and guidelines. Then 80% suggested that there should be training of laboratory and clinical personnel, and then for helping in developing a quality support system, a quality audit, and laboratory reviews. So from this survey, we identified potential IFCC, ISNS task force partner countries, their contact names, institution, and email addresses of those who responded to question, would you be interested in working with the task force to establish newborn screening program, was taken, and then a template was prepared to get orientation on their newborn screening journey through virtual meetings, followed by in-person meeting like this meeting today. So, the template, so what is important is that there should be a multidisciplinary group of committed national professionals within the country setting. And Diane has been talking about this from the beginning, that there's a lot of interest for Nepal from experts who are now have moved to overseas, but they are interested in supporting their country, and then there are other experts also. But it is very important that this group of individuals who are sitting here today, they should be very active so that other people can support from outside as well. Then there should be an infrastructure that could support the collection and transport of samples, and then offer confirmatory testing for screen-positive cases. We all know, as a clinical scientist, as a pediatrician, as a gynecologist, that there are screening, it may be false positive, false negative, and it has to be confirmed by a confirmatory test. So without confirming, and when it is confirmed, it has to be started with the treatment. So that is the Jugler-Vinson criteria, and again, the guidelines that the ISNS has published. So that is very important. And then with the confirmatory test, access to treatment should be there. And this should be affordable for the families to whom screening was to be offered. Because you can't leave a newborn screened and then have no access to confirmatory test or either to the treatment. So there are strong links to engage health policy makers and government officials for developing a sustainable program is a must. So I just tell you this, that currently the task force is active, so we had responses from other countries, but then these are the countries in the low side that we are active in, and Nepal is one of those. And we are helping to develop appropriate screening programs in association with the national societies and the task force members through support networking and information exchange activities. And we have seen the beneficial effects of this kind of approach. So these are some of the examples from Eastern Europe. We are their local champions and global support that is driving newborn screening. So Romania, Georgia, Bulgaria, Kazakhstan, they all had a basic national program, but they were unable to scale up safely to include inherited metabolic diseases. And then the capacity building for healthcare professionals and infrastructure to support the treatment of IMD patients was needed. So the task force with Madhab is working with locals to raise newborn screening profile within the European Parliament and the European Commission. The European Commission and the board of member states are interested in understanding the issue and encouraging development. So this liaison is going on for 30 plus members of the European Parliament who meet in Brussels to discuss the issues. The aim is to have a European advisory group on newborn screening to support policy development. So then this is an example from Asia. For Nepal, like we have come to this stage today, and then there is a, what is this, feasibility? So this study from Nepal has evolved after this year. And then in Sri Lanka, there's an interest, and Indonesia is making great progress. As I showed you, that from 4%, within 3 years, they have gone to 46% coverage for the newborn babies. And this is an example for Africa. So a significant progress has been made in Africa, and I think this slide is not clear, so it's all right. So what has happened that in South Africa, there's an advisory board has been formed, and in Nigeria, John Anita, who is the task force member, has developed a consortium with the University of Ibadan, and on newborn screening, and they are planning several pilot projects also. Algeria is also on board, and one of the task force members is very actively and proactively working to promote with an institution in France. And then Aga Khan University Hospital, where I work, they have a campus in Nairobi, Kenya. So they are, collaborating and supporting the Kenya campus to have an infrastructure with validation of the assays and all that. And their team was trained in AKU Karachi campus. And this is a group of Pakistan Society of Chemical Pathology, the webinar flyer that you see. So we conducted a program where across Asia and Africa, so we collaborated and we did, support networking. And again, to re-emphasize, with IFCC network, we developed new educational session, developing newborn screening in LMICs using innovative strategies. And further, we also